Hi, I'm Dr. David Hudesman. I'm director of the Inflammatory Bowel Disease Center at NYU Langone Health and professor of medicine at NYU. So my talk today at the ADH conference was about selecting first-line advanced therapies for ulcerative colitis. And the nice thing for our patients now, we have a ton of options, which is very different from just, about 5 years ago or so. And before sort of getting into the different therapies, I think there are a couple key takeaway points. I think first, the goals of therapy or the goals of care are the same. We want to get patients feeling better into clinical remission. We want to do that quickly. And we want to heal the inside. We want to heal the mucosa, put them into endoscopic remission. And we want all of this to happen off of steroids and obviously to sustain, right? So we want good persistence of our medications where you stay on them long-term and they remain into remission. The other important concept, and doesn't matter what therapy, is that you want to get patients on therapy early, right? So selecting what patient needs to be on an advanced therapy and not delaying with multiple courses of steroids or retrying oral or rectal mesalamine. The earlier you get patients on therapy, the better they do both in the short term and the long term. And there's really nice data looking at this, both in ulcerative colitis and Crohn's. More with Crohn's, we've seen some stronger data, but we've seen this with ulcerative colitis as well. So again, get them on therapy early, and it probably doesn't matter as much what therapy you put them on. Now, as I said, there's a ton of different therapies. So how do we decide? In the ideal situation, we would have head-to-head trials comparing one therapy versus the other. But for ulcerative colitis, we only have one. That's called the VARSITY trial, which compared vedolizumab to adalimumab. And bottom line, vedolizumab outperformed adalimumab. Saying that, we have a lot of other therapies. So we have to pull data from the randomized control trials, from real-world evidence, so what we're doing, what we're seeing in our practice, and then another type of evidence called network meta-analysis. That type of evidence you always want to take with a grain of salt. And essentially what they do with that is maybe they have one study comparing drug A to drug B, a second study comparing drug B to drug C. So then you try to make some assumptions to compare drug A to drug C. So putting that all together, we could then decide what's the best first-line therapy. So when making that decision, first thing you have to think about is efficacy, right? Because if it's not going to work, all of these other factors that I'm going to mention, it's a moot point. It doesn't matter. So efficacy is really important to think about the severity of disease, how quickly you need to get that patient better. Do they have extraintestinal manifestations, any other complications? After you think about efficacy, you need to think about safety, right? Is this a young female where you're thinking about she might be getting pregnant or thinking about getting pregnant in the next few years? And adherence is extremely important as well, right? Is a patient less or more likely to take a pill versus an infusion versus an injection? Is insurance going to cover those therapies? So how do I approach a patient with moderate to severe ulcerative colitis? If you're on the more moderate end of the spectrum. So what does that mean to me? The labs are pretty normal, maybe a mild elevation in CRP, but they're not very anemic. There's no significant or deep ulceration on colonoscopy. They're making it to work or school every day. That patient, I'm going to try a more targeted therapy. So this is where vedolizumab or our anti-integrins work, our selective IL-23 inhibitors and our anti-12/23 inhibitors, so ustekinumab, risankizumab, guselkumab, and mirikizumab, as well as our S1P receptor modulators, ozanimod and etrasimod. If the patient's on the more severe end of the spectrum, so somebody that's maybe CRP is extremely high, they're anemic, their albumin might be low, they have significant ulceration on colonoscopy, they're missing days of work or school, that's where I'm focusing on infliximab and upadacitinib. And sort of along that spectrum from moderate to severe, that's where I think the selective IL-23 inhibitors, as I mentioned, work very well. So again, treat patients early, right? Decide what's going to be efficacious, right? You're going to try something more targeted, as I mentioned, in a more moderate patient, because that might have a better safety profile. But if you have an extraintestinal manifestation, maybe you're going to try something a little less targeted, like infliximab or upadacitinib. So again, assess severity, treat early, and probably the first therapy you're going to choose will have the best shot of working. Thank you for listening to a summary of my talk.